regarding medical management and to prevent posterior segment complication, including endophthalmitis and TAS and CME. We have Dr. Prithvi Chandrakanth. He's a vitreoretinal surgeon at Chandrakanth Netralaya, Kozhikode. Over to you, sir.
Thank you, sir. Good afternoon, everybody. Good morning, everybody. So I'll be talking about management of post-op endophthalmitis, TAS, and CMAs. As you all know, there's a post-op endophthalmitis is a severe vision-threatening intraocular infection, typically occurring following any ocular surgery, most commonly after cataract extraction with intraocular lens implantation. So it's considered as an ophthalmic emergency requiring prompt diagnosis and aggressive management to salvage vision and the globe. So first of all, the whole thing starts from the reception onwards. So we need to actually train the receptionists to triage these cases whenever they see some red eye and all these cases, to immediately take them to the doctor. So history of the eye surgery has to be taken, very important. And what are the red flags? Symptoms: blurred vision, redness, and eye pain. You can have photophobia, floaters, and lid swelling. So all these are red flag symptoms, and this is the classification that we have to learn. That is post-op endophthalmitis, 12 to 24 hours. It could be TAS also. So we need to differentiate between TAS and endophthalmitis. And then the acute endophthalmitis comes until 6 weeks, and more than 6 weeks it is chronic. So differentiating between TAS is one thing is there is no infection and it's very rapidly onset, and it's sterile inflammation reaction, and vitreous will not be involved as much as the endophthalmitis cases. In acute endophthalmitis, more virulent, and patient ocular flora and wound related sources will be there, and it is very rapidly onset. These are all the organisms. In chronic, it is less virulent. Sources could be bleb related, lens matter, or any fungi. Low grade and slow progressive rather than the one in the acute phase. So task management, immediate recognition needs to be done within 12 to 48 hours. That could be diffuse limbal to limbal corneal edema, severe AC reaction, hyperpion, minimal or no pain, and clear vitreous. That is one differentiating factor which we have to look out for. And after immediate recognition, first 24 hours, you need to give topical eye drops, steroids, preferably prednisolone or difluprednate, eye drops of atropine for cycloplegic, and any AGMs like beta blockers or carbonic anhydrase. And if the cornea is involved, better to give a hypertonic saline also. And oral acetazolamide and avoid prostaglandin, because it could actually increase the inflammation. Post-op endophthalmitis, immediate action needs to be taken. Early management starts within the 15 to 30 minutes of suspicion. Earlier you diagnose, the earlier we can treat and salvage the eye. So the first thing, vision, light perception, and hand movements. This itself is the actual solution for our treatment also. So if it is light perception, immediate pars plana vitrectomy and antibiotics needs to be administered. If it's hand movements and better, always we can wait, or some people actually go in with the vitrectomy itself. IUP measurement has to be taken care of. If it is too high, it is always better to start AGMs. And then the signs and anti-segment, corneal edema, marked AC reaction, there could be hyperpion and AC exudates, along with the sluggish, poor reacting pupil. And in the posterior segment, poor retinal view, vitritis, exudates and ischemia. There would be snowball exudates in fungal, and severe iridocyclitis, and retinal abscess in the later stage. And if you cannot have a good view of the retina, it's always better to have a B scan taken. So the next thing is antechamber tap. So this is a very important step, that before we start giving intravitreal or intracameral antibiotics, it's always better to take an antechamber tap. You need to go in with the needle and take a small 1.1 millimeter of echo stab, and Vitreous tap also has to be taken. So again, the pars plana route, we take around 0.2 to 0.3 millimeter. And if you are anyway going to do a pars plana vitrectomy, always do a vitreous biopsy before you start the infusion. So always clamp the infusion and then do a vitreous biopsy. A 0.2 to 0.3 ml has to be taken, and once that is done, you can start the infusion, and then you can do the core vitrectomy. So this is a step that needs to be done, and we can send it for smear and sensitivity and culture to get a more better idea of what organism is causing the end off, so that we can treat them better. These are all the most common organisms responsible for endophthalmitis: gram positive is 75 to 85%, gram negative 10 to 15%. These are all the organisms, and in rare scenarios, fungal endoff with these species can be seen. And in established endophthalmitis, antibiotics when given oral or IV have really poor penetration into the vitreous cavity. It is always better to actually go with the empirical therapy. Hence, intravitreal injection are the treatment of choice, and intravitreal injection rapidly achieves the therapeutic levels at the site of the infection. So this is very important. For gram positive, because most of the cases were gram positive, vancomycin was given. Thus, vancomycin 1 milligram is given intravitreally. Gram negative, gentamicin was used, but because of retinal toxicity, it was changed to ceftazidime. So this is the concentration over here. This is for covering of gram negative. And for fungal, we give voriconazole. Again, it will be 0.1 milligram per 0.1 ml. And if for inflammation, we can give the dexamethasone injections also. These are all the dosage of each medical medicine, intravitreal medicine that we give. Also, no financial interest, but there is a oral lab e-kit which is available. I think it is for 2,000 rupees, which has all the medicine at the proper dosage already there in the box. So this is something which every hospital has to keep at least 1 or 2 stocks in their hospital. If any case of suspected endophthalmitis comes, you can just open this and give. Any adjuvant therapy in the first 24 to 48 hours: systemic fluoroquinolones, cefotaxime, gentamicin, and voriconazole. Any topical therapies like fortified antibiotic drops, cycloplegic, topical steroids, lubricants, and supportive for pain, analgesics, any agents for IOP increase. And this is a basic clinical management of suspected endophthalmitis. Take AC tap, Witter tap, and send it for culture sensitivity. It will come back within 36 to 60 hours. Re-evaluate and repeat the injections. So you can start the empirical therapy side by side. And if it's clinically worsening, you can also go again and give another antibiotic, intravitreal antibiotic. Or if it is worsening a lot, you can actually go in for a pars plana vitrectomy. Surgical management: if visual acuity is less than hand movements, or maybe failure of treatment of intravitreal empirical therapy, or progression of endophthalmitis, fungal endophthalmitis, and blood related and trauma can always be taken as surgical management. Theoretical advantage is that removal of infection organism and their toxins, removal of vitreous membranes prevents TRD, and provision of adequate material for culture, better for distribution of antibiotics also. And then disadvantage: it is very friable, inflamed, so necrotic retina is there, so it is very difficult, because any manipulation can actually go into complications like retinal detachment. These are all the sequelae that occurs. The prognosis with each organism: good with the coagulus negative, Staphyla aureus is moderate, the others are all poor. Candida species good to moderate. These are all the sources of each infection, each organism from where we get it. Staphylococcus from eyelid, most of it is in the ocular flora itself, and a few of them are Pseudomonas and Klebsiella can happen due to our hospital contaminated surgical instruments, and so all these things need to be taken care of. Risk factors, and I think the other things were already told by Gopal sir. So thank you.